Good morning, everybody. Welcome to another session of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today joined by our Medical Director, Dr. Pruitt.
Hi, Chief.
And also joined today by temporary upgraded Lieutenant Robert McGrath.
Hi, Chief.
Thank you, sir. Thanks for joining us. So today we wanted to talk about an interesting case that you have while you were upgraded over at Rescue 11. And it sounds like Rescue 11 was initially dispatched to a 13 Charlie for a 70-year-old female with some diabetic problems. So pretty common call, pretty common case that we go to. Just talk through with us what you're thinking about when you're en route to a diabetic emergency.
We're kind of just thinking whether it's going to be high blood sugar, low blood sugar, and just pretty standard on how to treat that and go forward with that.
Awesome. And then you arrived on scene, and tell us what you saw when you guys first arrived.
When we arrived on scene, she was sitting on the couch, and she seemed a little lethargic, but she was able to track us, able to talk to us through her daughter, who was, since she was Spanish-speaking only. Everything seemed normal. We right away got a blood sugar, and the blood sugar came back normal. And through translation, we figured out her biggest complaint was neck pain. And we kind of had some broken translation, but we also found out that she did have some kidney disease, but she wasn't on dialysis, and they weren't sure if she takes medications for her kidneys or anything to the extent of the disease. So it seemed kind of at that time like a not a big issue at that time.
Always a challenge with the language barrier and trying to get that kind of second or third party from the individuals. That always offers a challenge. So you kind of dive into that a little bit more. You had some just kind of vague overall symptoms. Talk to us a little bit about the physical assessment, what your findings were with the vital signs.
Our first set of vital signs were normal. There really wasn't anything that stood out. I had Sean Burns driving for me that day, and we got a rate of 72 on the pulse ox, and he confirmed that by actually checking at the radial. So we know our original rate was 72, and things seemed like they were going to go good, and we were expecting a pretty simple call. And just because of her age and the vague neck pain in that she was kind of pointing upper back, lower neck, we decided to do a 12 lead on her.
I think that's especially important here. I'm so proud to hear you say that. I think you did an excellent job considering age, comorbidities, and then the language barrier too with a initially kind of vague complaint. It's always wise to get a 12 lead. Excellent job.
Thank you.
Yeah, fantastic. So it looks like 130 over 97 for a pressure, 95 for a SAT, breathing about 14 times a minute. Good capno, 35, good waveform. Sugar, like you talked about, was good. When you were actually able to get her on the monitor and get the 12 lead, what did you all see?
Well, as we were placing the 12 lead, we noticed her head start drooping, and she got noticeably more lethargic, where we kind of had to hold her in place so she didn't fall off the couch. As soon as before we even ran the 12 lead, I had switched over to show the 4 lead on the screen, and that's when we noticed that she was bradycardic.
Interesting. So the initial vital signs showed a good rate. You palped that, matched it, and then you kind of saw a change in her presentation, and then that matched what was on the monitor to show a bradycardia. So 12 lead, fantastic job. That's the only way we're going to catch that. Talk to us, Doc, about bradycardia and what are the typical causes that we'll see in the field?
Yeah, so the way I like to think about bradycardia, there's 3 things. I remember die in my head: drugs, ischemia, and electrolytes. Sometimes in elderly people for the drugs, if they're on a beta blocker and maybe they're having worsening kidney function, or that beta blocker, they just changed a dosage or something, it's hanging around too long. I always ask about medications there, and it seems like you did that in this case, and she hadn't had any recent medication changes, so we can rule drugs out. Next is ischemia. So either some AV block or a lot of times hypoxia. Right before people code, if they're hypoxic, they get bradycardic. And so quickly addressing the airway. In this case, she was never hypoxic, so that wasn't an issue. So you're checking things off of your list here. And then lastly is electrolytes, and I think this is most important. Potassium, high potassium, can sometimes at the end stage manifest as bradycardia right before it hits that sine wave. And so those are the three things I kind of run through in my head when I'm trying to figure out why all of a sudden someone's bradycardic and which algorithm to take to treat it.
Absolutely. Great. And so now we kind of have a change in mentation like you described. So we're thinking this is more of a symptomatic bradycardia, even though her initial vitals didn't really tell that story. So talk to us about what your interventions and your next steps were after you saw her presentation and matched that with that profound bradycardia.
So quickly, we were able to get bilateral IVs fairly quickly, and we were critical level. So we didn't have 5.5 coming. So the first thing I did was call out for the engine to come help. They brought the gurney in as we were finishing up those IVs and started a fluid bolus right away. We gave her 1 round of atropine while still on scene, and we saw a little bit of an uptick in her heart rate. If I remember correctly, she came up to about 38 beats a minute. We were able to get her on the gurney, get her loaded into the truck, and we gave her another round of atropine, all while still giving the fluid bolus. And we got her up to about 48 beats a minute, and she pretty much stayed at between that 45 and 50 beats a minute range while we transported her to the hospital.
That's great. And then the normal bradycardia algorithm, doc, as we know, it includes fluid, which they did. They tried the atropine, sounds like 2 doses, which was working, bringing her rate back up. At what point are you wanting us to look at pacing? At what point do we make that decision? Like, no, they need electricity and this isn't enough.
Yeah, I think if your patient if you can say that they're unstable, and I usually judge that. I'm not sure how her mental status responded to your atropine. I know at one point she was in the 20s, and I'm sure that's when she was barely responsive. Did her mental status improve when she jumped
It did
into the
improve.
40s?
Wasn't really able to talk to her since I don't speak Spanish, but she was looking around and trying to communicate with me a little bit more. So we did have some signs of improvement with that.
Good. And then the next thing I would look at is just blood pressure, if they're perfusing or not. And it sounds like here she maintained her pressure.
Yes.
If at some point the mentation stayed diminished or the blood pressure was low, that's probably the point at which to move to pacing. And there's a recent article about pacing actually. With the anterior-posterior pad placement, you'll get a lot better capture. You'll use less electricity and you'll capture faster if you put your pads in the AP position.
And we talked about the patient's history of kidney disease, wasn't on dialysis quite yet, had the hypertension, had diabetes. Any findings on the EKG that was that led you down that this might be an electrolyte issue, kind of like Doc talked about?
In all honesty, with this one, no.
Okay.
Nothing jumped out. And even reviewing it today, I don't see any of the classic signs that might have jumped out to me. It was just kind of a weird call.
This was a fascinating case, which is why I kind of wanted to talk through it. Her EKG, if you're able to see it, classically we teach to look for peak T waves, especially in like V2 and V3. She didn't have those. Next, for severe hyper K, we tend to teach to look for a wide QRS greater than 120. She actually had a narrow QRS and looked to be in some sort of very slow junctional rhythm with a narrow QRS and normal T waves. But when she got to the hospital, her potassium was actually very high. I'm not sure I would have gone down the hyper K algorithm with this one either. I think what you did was exactly right, and it seemed to help her improve, and so you didn't need to go on to the pacing or the epinephrine. But I think the takeaway from this interesting case is with your bradycardic patients with renal disease, even though her QRS wasn't wide, I probably wouldn't have given her calcium. But if you feel like your interventions are failing or not working, it's always okay to take a step back and just ask yourself, could this be hyper K? And the treatment would be albuterol, right? Which truthfully isn't going to hurt, and the side effect of albuterol is it increases the heart rate, but it also may move some of that potassium if this is a potassium poisoning. I wouldn't have changed anything that you did. I think your approach to treatment was spot on. But that if you had a longer transport time, this may be one thing I would consider adding on just to see if it helps.
So at this point, you guys have arrived at the hospital, and I know the communication was difficult because of the language barrier, but was her presentation improved by the time you guys arrived there?
Minorly. It did improve a little bit, and even when we got to the hospital, she was still between that 45 and 50 range. She wasn't as alert as we would have liked, and that was kind of I could have given more atropine, but I wasn't seeing as much improvement as I would like to, so we kind of held off and just went with the fluid bolus and just get her to the hospital and let the hospital kind of figure it out from there.
Get her to the definitive care she needed, yeah, for sure. And lastly, Doctor, he brought up some great points in terms of, let's just say, if we didn't have a translator there, I think he hit all the right marks based on the presentation, but what should we be looking at with like elderly females? I know you touched on it a little bit briefly, but elderly females who don't always have the classic presentation, we're not seeing that something jumping out as far as a hyperkalemic patient, but what should we be on alert for when we're dealing with patients we can't communicate well with?
So I always cast a broader net, especially if I know that there's a language barrier, just like you did here. Ultimately it was neck pain, right? There was nothing that says screams, get a 12 lead here. And I think you did the same thing with elderly females, especially diabetic elderly females or other risk factors. Their presentations of cardiac emergencies are not always textbook chest pain calls. And so I think any pain above the belly button or into the neck on the patient with the right risk factors, it's always wise just to get the 12 lead and make sure that's not your problem.
So newly upgraded into the position. I know you'll be testing soon. You'll be promoted soon.
Hopefully.
Just a good learner for everybody, right? So what are some key takeaways that you learned from this call, things that you would do differently, do the same, and how would you pass that on to the next upgraded officer that comes to take this type of event?
I think one of the biggest takeaways was calling for help early. Sean's an intermediate, so at least I did have some help with an IV on that, but we were atypical, and we were going to need help loading her, and I'd like to have extra hands in the back of the truck, so being quick to say things aren't going great, I need more hands on, I think was a huge help on that one.
Absolutely. 13 Charlie, you're just going by yourself as a rescue with no ambulance available. I think getting those other resources early, that's key to help you be able to focus on the patient and not get task saturated. So I think you did a great job with that. One other thing I thought through that I'm still waiting on a specific answer for, but it's my understanding that we still have access to the Globo services is the name of the company that does they can serve as interpreter services for us. Have you guys ever tried that over at 11's? Have you used it yet?
We have. More recently, we've used it for a couple weird, I think we used it for Kandar or something like that. But, and we, as a station, we've gotten better at like remembering and writing down the passwords and the information to get onto it.
That's great, and I think it's important for us as administration to get that information out to folks because people don't use it regularly because it is a rarity, but there are those circumstances where it's beneficial. I think we can sign in, and it gives over 100 languages. You can even do sign language through that as an interpreter service. So another great mechanism just in case we have a situation where there's no family present to help us. So
Great.
Fantastic job.
Thank you.
Doc, any closing thoughts on this specific case?
I don't think so. I think you did a fantastic job. Yeah, couldn't be prouder.
Thank you.
Yeah, it was great. I appreciate you taking the time to bring it to us and share your experience and your knowledge. That was fantastic. That's all we have for today. If anybody has any additional cases that they think are interesting that they'd like to come talk with us about, you can go through SharePoint and do the submission or reach out to anybody in the EMS division. Until then, we'll see you next time. Thanks.